This is quite interesting case. So 34-year female patient who was myopic came to us with a complaint of sudden decrease in vision in the right eye with associated headache and disorientation, and she's a known thyroid on treatment. So on examination, her best corrected visual acuity was 618 and 612. She's known thyroid on treatment. Right eye anterior segment was quite, pupil was reacting for both direct and indirect, and restriction of abduction was noted with tessellated background. Left eye anterior segment was quiet with no restriction in the extraocular movement with a myopic background. Diplopia charting showed uncrossed diplopia with maximum separation of dextro elevation, version and dextro depression. HFA showed right-sided homonymous hemianopia with macula sparing. Now we have three positive findings: pupil reacting to light, right-sided homonymous hemianopia and diplopia. Let's decode each one of them. Pupillary pathway and the visual pathway are common till optic tract. So at the optic tract, the pupillary pathway goes to the midbrain. So if pupil is reacting to light, it gives a clue that the lesion is somewhere beyond the optic tract, maybe an LGB, optic radiation, or somewhere in the occipital cortex. Now right-sided homonymous hemianopia with macula sparing gives a clue that the lesion must be in the somewhere in the left-sided occipital cortex, because occipital area have a dual blood supply. Now this patient MRI has been advised. Let's see what is there in the MRI. So MRI shows acute and chronic infarct involving left parieto-occipital cortex with raised intracranial hypertension. This is a case of right-sided homonymous hemianopia with macula sparing due to acute and chronic infarct in left parieto-occipital cortex with right abducens nerve palsy due to raised intracranial tension. So this is how we decode the neuro-ophthal case.